This is chapter 43, alterations in digestive functions in children. Thanks to Elsevier, the publisher, and McCann's book, Pathophysiology, for a lot of the content in this presentation. So one of the major things that happen in children is cleft lip, cleft palate. Both affects the development abnormalities of the first brachial arch. Both are caused by multiple gene environmental interactions, particularly maternal deficiency of vitamin B6 and folic acid, B12, maternal alcohol, smoking, diabetes, steroids, statins, and other genetic malformations. These factors reduce the amount of neural crest mesenchymin that develops into the embryonic face. Cleft lip is caused by an incomplete fusion of the nasomedial intermaxillary process. Commonly occurs in the first nostril, but the defect can be bilateral, symmetrical, asymmetrical. And cleft palate occurs from the incomplete fusion of the primary palatal shelf during the third month of gestation. Is commonly associated with cleft lip, but it can occur without it. And these are some of the pictures of various forms of cleft lip and cleft palate. This is just a cleft lip in A. This is cleft lip with the separation of the upper palate. This is bilateral, and this is where there is no cleft lip, but the palate is divided. Obviously, if these were left in place, a lot of food would be abnormally placed, and people could be get many complications. So clinical manifestations: feeding difficulties, treatment, surgical correction in 3 to 6 months, special bottle for feeding. Breastfeeding may be possible for some infants. Orthodontic prostheses, parental prenatal education and support and evaluation for hearing loss, which can be concomitant. Esophageal atresia, the esophagus ends at the blind pouch. Endodermal cells inhibit it causes defective growth. And then you can have tracheoesophageal fistulas, as an abnormal connection between the trachea and the esophagus. Various forms exist. And this incomplete fusion of the lateral wall of foregut leading to incomplete closure. These tracheoesophageal fistulas can be quite difficult and deadly because of them. And these are the esophageal atresia in A, right? And this is a tracheoesophageal fistula. This is where the esophagus actually ends in the trachea. This is where it's kind of side anastomose and where they can interplay with each other. And you can see what kind of difficulty that would create, having gastric and feeding contents going down the airway. Esophageal malformation by pathophysiology, post-viral infections, environmental, genetic, swallowing amniotic fluid, classical manifestations, esophageal atresia, drooling, choking, swallowing difficulties, respiratory distress, fistula, recurrent aspirations, pneumonia, and atelectasis, which you can see by those pictures. Treatment, aspiration, prevention, surgery is usually undertaken after birth, sometimes in stages. Infantile hypertrophic pyloric stenosis. The pylorus is the valve between the stomach and the jejunum, and so if that fails to open, then the poor child's going to have hypertrophic sphincters. Risk factors include gastric secretion by the mother in the late trimester. Overproduction of gastric secretion may cause stress-related factors in the mother, and then exogenous aspirations. So increased risk of family members who have pyloric stenosis. So the circular muscle of the pylorus is grossly enlarged, hypertrophied in size, mucosal lining, pyloric fold, and lumen narrowing, encroaching it. As a result, there's a peristaltic effort needed to get forced gastric contents through the narrow opening. So it's really a stenosis by hypertrophy, whereas most stenosis in adults are caused by injury or scar. So clinical manifestations: projectile vomiting after feeding, vomiting causing weight loss, fluid electrolyte balance, chronic malnutrition, dehydration, can be fatal in 4 weeks. Treatment: pylorotomy, when the muscles of the pylorus are split and separated. Fluid electrolyte losses are managed before surgical intervention. Children can usually tolerate feeding after several hours after. So pyrostenosis is associated with all these things. Sound interesting: diarrhea, anorexia, increased maternal cholecystokinin, but they're the wrong answer. We just talked about the muscle hyperplasia, which actually leads to obstruction of the pylorus. Obstruction of the duodenum, jejunum, and ileum are caused by intrinsic malformations, atresia, stenosis, or external pressure. Stenosis, narrowing of the lumen, causes dilatation proximal to the obstruction. Obstruction may be partial or complete. Intestinal malrotation: the ileum and cecum normally rotate during the 10th week of embryonic development, enable the cecum to be in the right lower quadrant and fixed to the abdomen by mesentery. Malrotation and normal rotation does not occur. And pseudoduodenal bands or lappet bands: the colon remains in the upper right quadrant as an abnormal membrane may press on it and obstruct the duodenum. Malrotation: intestines can twist as a result of twisting into a volvulus and causing obstruction. Remember, we talked about that in the adults of volvulus is twisting, right? Clinical manifestations: bile stain, vomiting, intermittent persistent feeding, dehydration, electrolyte imbalance, fever, scant stools, diarrhea, bloody stools. Treatment: reduction of volvulus, laparoscopic or open, LAD surgery. Necrotic bowel has to be resected, primary anastomosis, and enterostomy. Can be life-threatening issue. Meckel's diverticle is outpouching of all layers of the small intestine wall, usually in the ileum. Most common congenital malformation of the gastrointestinal tract. Rule of 2 occurs in approximately 2% of the population. 2% of developed complications, usually associated by 2 years of age, is located 2 feet within 2 feet of the ileocecal valve. The ileum and the cecum, right? The ileum is the ileocecal valve is where the small intestine connects to the large intestine. It's located at 2 feet, and the average 2 inches in length. You might have an adult patient that you get a colonoscopy before saying they have Meckel diverticulum. Develops when the certain mesenteric ducts fail to obliterate, which normally leaves fibrous bands. Clinical manifestations: asymptomatic, most common is painless rectal bleeding. Treatment: surgical. Hirschsprung's disease is obstruction of the colon, most common cause of obstruction, colonic obstruction in children, caused by a failure of the neural crest cells to migrate into the GI tract and skip segments. Delayed passage of meconium, poor feeding, weight gain. Surgical treatment is the best way to treat this. Other obstructions: idiopathic intestinal pseudo-obstruction and distal intestinal obstruction. Many unfortunate things can happen to a newborn by all these malfunctions. Distal intestinal obstruction syndrome, formerly called meconium illness, associated with cystic fibrosis. I know we keep repeating this, but the cystic fibrosis is the most common genetic abnormality in the human cycle. Intestinal contents abnormally thick, partially and completely impact the bowel or intestinal lumen. Impaction frequently occurs after periods of dehydration and lack of pancreatic enzyme treatment. Hypertonic enemas. Anorectal malformations or anorectal agenesis or atresia, deformities that cause complex obstruction. Of infants born with anorectal malformation, 40 have other abnormalities such as Down syndrome, Hirschsprung's disease, duodenal atresia, neurogenic bladder, and spinal malformation. I don't know if you remember, when we were talking about genetics, then we were talking about some of the poor pictures of these poor children with rare genetic abnormalities, and I said that many children are not born with one genetic abnormality, such as, say, cystic fibrosis or Down syndrome. Many are born with many other problems. And so it behooves everybody to keep these in mind when you're dealing with these children, even as young adults, that they may have had many of these problems. Treatment: anal stenosis is dilatation. Other anal rectal malformations require rectal perineal fistulas, which are quite devastating because they leak into the pelvis, and rectal vaginal fistulas. Meconium syndromes is substance that fills the intestine before birth. Meconium plug syndrome, benign bowel obstruction. Meconium aspiration syndrome, gasping respiration that causes meconium aspiration. And meconium ileus, abnormal sticky meconium, causes intestinal obstruction. Gastroreflux, esophageal reflux disease, return of stomach contents into the esophagus from relaxation or incomplete competence of the lower esophageal sphincter. In newborns, reflux is normal. Neuromuscular control of the GE sphincter is not fully developed. Infants usually outgrow this condition. Cause: ineffective protective mechanisms. Persistent reflux, mucosal erosion, bleeding, dysphagia, and failure to thrive. Genetic and environmental and anatomic and hormonal factors can lead to this. And esophilic esophagitis is a differential form of GERD that can occur in children. With atopic disease, immediate delayed hypersensitivity, common symptoms: dysphagia, food impaction, vomiting. Treatment: elimination of these diets and corticosteroids. Treatment would also be thickening and feeding, small frequent feedings, frequent burping, positioning, medications. To improve, no improvement, anti-reflux surgery. So you try conservative treatment. Intussusception is the telescoping or invagination of one part of the intestine to another. Causes obstructions. Most common scenarios are ileum invaginating the cecum. Mesentery constricts, and the obstructing venous return, leading to venous stasis, engorgement, edema, exudate, and polyvascular compression. If untreated, bleeding, necrosis, bowel perforation, gangrene, and death. The appendix is here, and this is the colon, and so the cecum is invaginated, and here's the appendix now up here, pushing everything inside and causing an obstruction. Manifestation: abdominal pain, infants, irritability, colicky, flexion in the knees, vomiting occurs as soon after the pain begins. Current jelly stools appear dark, gelatinous as mucus. Treatment: edema reduction, if not successful, surgery, if not enema reduction, if not successful, surgery. Left untreated, fatal. Infant rise in emergency department with diagnosis of intussusception. Which data will the nurse typically find in the assessment? Olive-sized mass in the right upper quadrant, meconium illness, painless record, current jelly stools, which we just talked about. If there's no, if one portion of the bowel is the jejunum is invaginated into the distal colon, the colon is still going to make mucus, and the mucus is going to be bloody because of the trauma that's occurring. Cystic fibrosis is genetic transmitted disease, dysfunction of a CRTF program, involves many organs and systems, usually causes death in childhood or young adult. Deficiency of pancreatic enzymes, digestive enzymes, results in overproduction of extreme viscous mucus and pancreatic enzymes. The classic triad is deficiency of pancreatic enzymes, overproduction of mucus in the respiratory tract, and abnormal elevation of sodium chloride concentrations. A truly profound metabolic problem. Yet these children look normal, but they have pancreatic insufficiency, obstruction of the pancreatic duct with thick mucus, blocked flows of pancreatic enzymes, degenerate fibrate changes. The pancreas damage can eventually lead to beta cell, resulting in diabetes mellitus. Clinical manifestations: growth failure, glucose intolerance, chronic lung infections. Evaluation: 72 hours of fecal fat measurement determines the extent of the pancreatic function. Treatment is high caloric, high protein diets, growth hormone, and sometimes enteral substance